Hi guys, hello, I'm Shani and welcome to another episode of the conversation between the two of us with myself, Makungu Baloyi. And thank you guys for watching my previous video, for growing the channel with me, continuing liking, subscribing and sharing the content. I really appreciate it. So today it's a conversation between me and a special guest who I'll introduce shortly. So yeah, welcome. We'll be talking about PCOS today, Polycystic ovarian syndrome, and our guest will give us everything we need to know about it. So yeah, do continue watching this video and let's hop right into it. Like I said, today it's a conversation between me and my boo, Dr. Khanibee, Dr. Ceci, Mrs. S, whatever she will tell us what she wants us to call us on this platform. But to me, she's Dr. Ceci, Dr. Boo. And yeah, welcome. It's nice to have you here. You're my first guest. Can you believe that?
Thank you, Boo. Thank you. It's such a pleasure and honor to be here, and thank you very much. I'm looking forward to be talking about PCOS as we approach the month of awareness of PCOS in September. So yeah, I'm excited.
As we end
the month.
Yeah, so I think the whole point of the episode is just to recap on the month of September, Polycystic ovarian syndrome Awareness Month, and to leave you with tips. So I always think that awareness does not end in 1 month. We talk about the conversation all the time. So yeah, so welcome, Dr. Ceci. Maybe introduce yourself to the people. Tell us who you are, what you do, and maybe tell us one fun fact about you.
Alright, so my name is Makanan Baloyi, known as Khanibee on social media, Instagram and Twitter. I am a medical officer by profession. I'm a medical doctor, currently doing Obs and Gynae as my department, and I am working at Shelmakeke Johannesburg Academic Hospital. So that's who I am.
I said one fun fact about you.
Fun fact about me. What's a fun fact about me?
I don't know. You must tell us. Surprises.
It's not actually fun, but
what is this?
I'm the bravest person. I don't know. I like doing adventurous stuff.
Okay, so you have high adrenaline.
Yes.
Okay, all right, cool, got it. High adrenaline. I guess you're an adrenaline junkie, right? So that's one fun fact about her. So those who don't know her on social media, because she also serious on social media in her scrubs.
Am I serious?
You're not serious.
I'm not always serious.
But you are very serious. You're a serious sister. Like you are. Like you're Dr. Khanibee is a very strict sister, guys. She's very strict and serious.
I'll take that.
She will. Because she is. But yeah, so I think let's hop on right into the conversation. And I think the very first question to frame our conversation, maybe just give us an understanding about what PCOS is. I mean, we use the acronym a lot. What does it stand for? What is the condition? Just give us like basic facts about PCOS.
Okay. So PCOS, like you've already mentioned in the introduction, it stands for Polycystic ovarian syndrome. So it is one of the most prevalent metabolic or endocrine disorder, especially in reproductive age women. So as September, as you know, is the awareness of PCOS. So PCOS consists of a syndrome, which is a combination of symptoms. So there are 3 major criteria or features that distinguish this definition of PCOS, which mainly is 1, hyperandrogenism, and secondly, an ovulatory dysfunction or menstrual irregularity, and then the last criteria, which was mentioned by the Rotterdam criteria, currently added into the definition of the whole syndrome, would be the polycystic ovarian morphology. So those are the big features of polycystic ovarian syndrome, which will unfold later in the episode. Yeah.
Okay, that's big English, like very big English. Even me as a learned someone, I'm very learned, but that English is very big for me as well.
Okay.
I didn't mention this, but I do have PCOS. I've been living with PCOS.
Yeah.
I was diagnosed with PCOS officially in 2019. But my journey, I will unwrap my journey as she explains and use that more of a case study of my journey. But maybe like break it down in terms of layman terms, right? So if I'm someone listening and I'm watching and I'm a woman, I want to understand this definition. Okay, you said and you see, I can't androgenism. You see, it's such. I don't even know what that is. Break it down. Like, what are the basic, in layman terms? So, what am I looking for when I want to know what PCOS is, or how to identify if I'm starting to have PCOS symptoms?
So in simple terms, what PCOS or polycystic ovarian syndrome is, it's a disorder that consists of various symptoms, and these symptoms will manifest usually with irregular menses or your menstrual cycle, and secondly it will manifest in what we call high excess of androgens or hormones. Let me just put it like that. So high excess of hormones or androgenism, and we see this through excessive hair in female, whether in the chin, the upper lip, and your abdomen, thighs, and at the back, where usually normal women will not have hair in those areas. And then lastly, it will be a more of a clinical, or what the doctor will diagnose you with, which is the physical cyst or ovarian cyst that the doctor will see and diagnose you in ultrasound or a sauna, for simple terms. So it's just a disorder that consists of all the symptoms, and for you to have it, you have to have at least 2 or more of the symptoms that we're talking about, which will be the excess hormone production, irregular menses, the physical or clinical diagnosis of a cyst inside, and also infertility. So that is part of in simple term, what PCOS is.
Okay. So you've already mentioned the major symptoms, like the hirsutism, where you grow your hair under your chin and etc. And also things like irregular menses, right? Yes. So quick story, when I was growing up, I used to have irregular menses, but so did you have irregular menses at some point in your life, right? And then because mine persisted, my parents obviously took me to a GP, because in small towns, you know that we don't have access to gynecologists, right? So our next line of help would be a GP, right? And my GP put me on the pill, right, for the longest time. So I was on the pill, and sometimes I was taking it, sometimes I was not compliant, because, I was in grade 10. No one is telling me anything. They're just saying you just have irregular menses and you just take this pill, it should help, and you go about your life. Until years later on, when I was growing up, going to university, I started obviously having hair under my chin. But I think what for me was the worst was I was in so much pain. So I had so much pain in my abdomen, which I think was the cysts that were growing. And then I had to go see a gynae. And then the gynae obviously did multiple scans. I have laparoscopic scans. I had multiple things that were done for me to then get the official diagnosis, right? But what about someone who is given the pill, like ours, from the GP, and then they sit and say, it's just irregular menses. The doctor says, and by the way, when I was on the pill, your menses regularize, right? So because when I take them properly, so in the months where I'm not compliant, I would skip. There was a time in university where I would skip 4 months because I didn't want to take any form of pills. I was tired. But what happens to someone who was told by their GP that just take the pill, it will regularize your periods? When do they have to act and say, I've been on the pill, but is this all? Is this the help? When is it the right time for someone to stand up and say, let me go seek further help, because this is just not irregular menses?
Okay, so to answer your question, usually PCOS, they say that 70% of women actually go undiagnosed of this disease. That's how complicated it is, and that's how much people don't know about the disease. They're unaware or misunderstood. Even doctors themselves sometimes tend to not diagnose patients or young adults and girls on time. So that is the other part of PCOS, and hence that's why we're having this talk, because a lot of people go undiagnosed. So PCOS also is an incurable disease. So you can't, there's no cure as yet, but then there are medication and everything that you can do to manage the symptoms that actually occur. However, even because, like I said, it's a endocrine disorder. When you go to a doctor, there are certain endocrine and metabolic diseases that your doctor needs to exclude.
Okay.
Before we can say you are diagnosed
Like
of
what?
PCOS. So there are other metabolic or endocrine disorders like thyroid disease. There are others like Cushing syndrome. So Cushing syndrome will be like the disease which we have central obesity, you have high blood pressure, and all those things. And other congenital adrenaline or adrenaline, congenital adrenaline disorders that you have to do. So any endocrine disorder or androgenic disorder have to be excluded first. So this is why your doctor will then take blood tests to see the different hormones, biochemical, and test the levels like cortisol and all other androgens. If that is inclusive, you cannot say you have PCOS. So you have to exclude this to have a definite.
So you must first deal with it.
If that is excluded, we are saying it's not this part of androgenic disorder. Then maybe we're looking at something else. So this is why you say, okay, even having irregular menses, like you were to say, you've been taking pills and now, yes, your hormones are regulating or it's becoming worse. Then there are other investigations that needs to be done to have a definite diagnosis. And hence, that's why PCOS is very difficult to diagnose.
Okay, but as a patient, right, when do I stand up and say, okay, I've been on the pill for a while now, but I don't see much change, right? Or because some people don't want to be on the pill forever, right? So in my mind, I think if you're put on the pill just to regularize your hormones, you should be able to then get off it, right?
Yes.
And then your periods are regularized. So let's say I did that route, I get off the pill, and then they regularize maybe for a month or two, and then I go back. When do I say I need to go for further investigation? When, as a doctor, when do you recommend for patients and for women? Because I think, but for me, I think living with PCOS made me realize that especially Black people, we ignore pain a lot, right? So because you grow up being told it's okay to have painful periods, it's okay to have all of these things, and then we don't go seek further help. When do you think it's the appropriate time to go seek further help to get a proper diagnosis?
I think you have to go back to say, why was your reason at first to go and see help for your irregular menses? What was the cause then, and have we managed and we solved the problem? If your answer is yes, then it's either you decide to stop it with your doctor and everything. What we have, the cause of the irregular menses have now been solved. However, if new symptoms then come on board, like acne, alopecia, maybe you're trying for a baby and now you're off the pill, and then there's other symptoms or new developments, that's when maybe further investigation has to be done to say, maybe we're not looking at the primary cause, which we thought was, maybe there's a new diagnosis that maybe we are missing. So if your symptoms get worse, if new symptoms develop, then that is when you should revisit either your GP or a specialist to say, okay, you see, there's something new that came in, there's 1, 2, 3, or I have irregular, or now I'm not going on my periods anymore. Completely. I was before, it was not as irregular, but now completely I'm not going. So that we can revisit to see why we have to manage the problem here.
That's understood. So I think, I hope if you're listening, you have that urgency to go and find help, because I think as we're Black people, I don't know why I keep saying Black, but I don't know if it's a medical thing that's proven in the medical field, but I think Black women, we have a high threshold of pain.
And also, we found only these things when now we want to give birth.
But exactly.
Now I want to have a child. I'm trying to have a child with my husband, and only then will I then discover that I have this thing, only to find out that actually this thing started when I was still in high school, or this thing started when I was still in primary, and I just did it, I just ignored it.
And you could have managed it and found ways to improve.
Or you are put on the pill and you're like, oh, okay, now I'm starting to have hair. Maybe it's part of the hormones. So like you're saying, we tend to ignore certain symptoms and we think it is normal.
Okay. Maybe now let's move to the treatment, right? You did mention in the beginning that PCOS has no cure. So that was the most frustrating thing when I was diagnosed, right? So my gynae said there's no cure. And then I was like, and then? Okay, then how do I live with something that there's no, is this a death sentence, you know? Because I think for me at the time I was 24 or 25, and when they gave me the verdict of, why do I say like it's a court order? When they diagnosed me of PCOS, my guy, like, what is it? What is it? And for me, the worst part was it came with multiple stuff. So I also was diagnosed with endometriosis at the time because we did a laparoscopic cyst. I had cysts, I had fibroids. Exactly. So I had all the whole shebang.
The whole reproductive
disorders. So I was like, am I now going to become a lab experiment of how to manage PCOS, endometriosis, fibroid cysts? I was like, this is a lot for me. And the one thing she mentioned when we were in after my surgery, and she then mentioned, but there's no cure, we'll just try and manage what we can and deal with the symptoms as they come along. So maybe walk us through, for someone who might know now that they've been diagnosed, they know, and then how do they find treatment or management, especially because it can be frustrating to be told there's no cure, and you can easily give up and say, because there's no cure, I'll just live with this thing, there's nothing I can do. Is there something we can do, and what is the management plan for those living with PCOS?
Managing PCOS, like I said, is quite difficult because then it's individualized.
Okay.
So you might have certain symptoms that I wouldn't have, and you still have PCOS. So according to the criteria, like I've mentioned of Rotterdam, there are different phenotypes or different criteria. So one would have these symptoms, which will be just infertility and herpesism or egg. One will have ovulatory dysfunction plus polycystic ovarian morphology. So those different types, you are treating the symptoms, you are not treating the whole disease. So there's no cure, but then we are managing the symptoms. So when a patient comes to me, I look at what are the symptoms and we try to alleviate those symptoms and manage them. However, PCOS is not just medically treated, there are also lifestyle interventions because it's a multifactorial disease, which could be genetic, environmental, or other factors that come into them. Although it's not quite understood, the whole etiology and the pathogenesis of PCOS.
What's pathogenesis?
Pathogenesis is how is this, what is the cause of it? Like if you were
to trace back with the root cause or what caused.
So the whole pathophysiology of PCOS, how is it formed, and what is the cause for it. So now when you come to the treatment, you treat it individually. However, the main treatment that usually we see, so let's say now you are coming, the mainstay treatment that has been used for many years is Metformin. So Metformin is...
That's diabetes. Guys, she's not telling you the truth. Metformin is diabetic medication.
It is.
So let help us understand why we get... I was put on Metformin for like a year, 6 months. And the fact that even when you go to the pharmacy, people look at you funny, like, do you have diabetes at a young age? You know? But why do we have to, and I think it's a point we forgot to mention in the beginning about insulin resistance. So maybe just speak a little bit about what that does.
We put them on Metformin because PCOS on its own, it's a disorder that has insulin resistant. It put you in a risk of having diabetes. Okay. So there are other risk factors like cardiovascular disease, high blood pressure, insulin resistance. So that's why we put you on Metformin. Not only for insulin resistant, but also apparently it can actually trigger the hormones. So in terms of ovulation, Metformin.
So it can cause you to ovulate.
It can cause you to ovulate. So it's part of the treatment. So like I say, we are treating that insulin resistant. We put you on Metformin, and secondly, you can put you on oral contraceptives. So if you are looking at irregular menses, then we're treating that irregular menses, like we've mentioned, oral contraceptions. Then thirdly, we also give you spironolactone. Spironolactone, for those who don't know what it is, it's a hormone or a drug that also stimulates manipulate androgens.
Okay.
Or especially for patients with hirsutism or excess hair, then they put you on that.
Okay.
If you have infertility issue, then we also put you on medication for infertility drugs. So that's how we treat PCOS. There's not one drug that we give for this disorder. We are treating the symptoms, and sometimes that's how it can become difficult because we give you so many medications.
That's where I want us to go in terms of the discussion, that because there's no one pill to cure PCOS, and I actually find that the management of PCOS is contradictory, because at the one side they will tell you for insulin resistance to be managed, you must lose fat, right? So fat makes you more at risk to have,
especially obese patients with
right?
increased BMI.
Exactly.
Yes.
But then you put me on the pill because you're trying to manage my menses.
Yes.
The pill causes me to gain weight. That's one of the side effects of the pill.
Hence I said there's lifestyle interventions. So you have to go to the gym, you have to have a balanced diet, and that's not.
But that's a lot.
It's a lot.
It's a lot.
But then that's what is required.
And because
it's not just treated on medication. There are other lifestyle interventions that you should take on.
Because even those lifestyle interventions, right? It becomes harder for you to practice those lifestyle patterns, because let's say, for example, when I was on Metformin, I would feel very nauseous. Like I wouldn't feel like myself. But I must go to the gym. Like how do I go to the gym when I'm feeling nauseous and I'm feeling I'm gonna go vomit all over the treadmill? You understand? For me, I feel like,
unfortunately, those are the side effects that your doctor should have told you about when they give you this medication. Every drug has a side effect, and also it has the advantage and disadvantage to the drug. So to counteract that, there are other ways you can do it. Diet, exercising, it's part of the management of PCOS, of which
a hard disease.
Sometimes we take you through to a dietitian to explain you the types of food as a patient or as a woman who is being diagnosed of PCOS, foods that you need to avoid, like dairy, gluten, and all those kind of things.
My gynae
will trigger this symptoms with acne, especially with acne and other symptoms that you could have in the spectrum of
my gynae actually did recommend a dietitian, and at some point I was put off dairy and gluten. Dairy I didn't struggle because my whole family, I think we're all lactose intolerant. If we're being honest,
in denial.
The whole family, like from the father to the cubs, like everyone is lactose intolerant. So I didn't struggle much with the dairy. But the gluten, oh boy, guys, I love baked goodies. Like I love cakes and stuff. So it was hard. So for me, I feel like that's the frustrating part of living with PCOS, right? That there's no one treatment, one form of treatment, but also the treatment in itself is contradictory. And then for me, I feel like there's another layer that becomes a mental health problem. Because even some of the medication causes mental health strain, and you also start feeling stressed by, am I doing enough as a patient living with PCOS? Because they tell me eat right, you're trying, but then sometimes the pills can make you have cravings. And then now you're craving stuff. Do I satisfy that urge, or do I so I feel like there's just a lot of juggling, and
it's a journey. It's something that you have to tackle with, and it's like any other chronic disease, diabetes. If you think about the whole disease,
so can we say that PCOS is a chronic disease?
I wouldn't say that.
Okay.
Yes, I wouldn't say chronic, but I'm trying you to understand the management, and for you to understand with someone who's living with diabetes, how they go through this thing every day. They do crave sweet stuff, but then it's the discipline, knowing that I have been diagnosed with diabetes. This is the treatment. If I am obese, I have increased BMI, or then I need to exercise, I need to stay away from this kind of food. Same thing applies with PCOS. Same thing applies with other disorder like hypertension. It's quite difficult, but then if you understand the disorder and you have support of people that know that you are indeed diagnosed with this disease, then you'll be able to manage it, especially the support.
I think for me the support is important. And I think even support in terms of those who are maybe married or in relationships and you have a partner. Even how I actually asked a few questions on my Instagram around PCOS, and if anyone has questions, and I think we've tackled some of them. The main questions were around what the disease is and what the main symptoms are, and what are the early signs. I think we've already covered that. But there's one comment that says, does it affect one's sex drive, and does the contraceptive pill help? Because I think as someone who's living with PCOS, there is also an element of how the disease affects your sexual health, right? From vaginal dryness, there are many things. Your libido can be low, and as you mentioned, support. And I think that's very important, that even your partner then understands and can be able to offer the support. So maybe in answering the question, does the condition PCOS affect your sex life?
I'll say in terms
your sex drive?
Of your medication that you're taking. Oral contraceptives does cause depression. It's one of the side effects. It does cause a low libido as well. So it's quite difficult because now we're giving you this medication, but it has this side effects that it helps. So I think if you are aware that this is the kind of, PCOS itself can cause depression, anxiety, and all that other mental issues that comes with it, because the disease itself is such, it's weary to patients, especially if you don't understand what is going on. But in that element, yes, I will answer it does cause, if you're thinking of it in a mental health issue. But then the oral contraceptive itself, some people complain that they give them severe depression. Some will say, I don't have any sex drive. But if you are aware of it, like we're saying, if then you make yourself aware that, okay, I'm actually having these side effects, what can I do to better the side effects? You either change the drugs with your doctor, or you can continue taking them, but then counteract it with support from your husband or your sister or your mom, that will give you more support to say, okay, you have this is what is happening to you, it's okay, I understand, and you have my full support that it will be okay. You understand? And then also, like other lifestyle interventions, gym can also help.
Oh, guys, why is
gym will also help you, like, different kinds of food to have your mood, have those other hormones that are going to help you in terms of sex
endorphins
drive.
That's what they call it.
Yes, like sex drive. So try to be active. Yes, you might have side effects from the medication that you are given, from the disease itself, but then if you look at it in a whole other spectrum, that it's not just medication, there are other things that's going to help you: spiritual life, mental health care.
I think for me that's the hardest part with living with PCOS, is the many things. So if you think you've conquered one thing, another thing has to be treated now. So if now you have regular menses, now you must deal with your depression. If you now have depression, then now you have a cyst burst.
It's like being diagnosed with cancer. Do you think those people don't go through depression? They do. But even the pills themselves, chemo and radio, whatever, it makes you tired. Like you don't have the strength for it. But it's saying
the support
I have support, I have this disease, I have this medication that's making me tired, but I'm going to get up every day and say, okay, this is what I'm going to do.
I think to add on the issue of support, right, guys, stick to one gynae. Like I am speaking to you.
Well, that's actually true.
Like stick to one gynae. I will not. I know we, especially as patients, it's our prerogative to choose gynaes. As patients, we can help when we don't feel,
especially if you don't know what the diagnosis is. It's like, now, okay, I have irregular menses, now I have fibroids, now I have infertility, but you haven't got, let me try. But then sticking to one, like you're saying, they have your medical history. It's easier to go back, okay, we've tried this, let's not try this, or recommend it to someone else. If then your gynae actually recommend it to a subspecialty, because there are subspecialties that actually deal with that only, then it becomes much better.
Because for example, when like I said earlier, that I unfortunate event of having endometriosis, PCOS, fibroids, and cysts. So last year when I ended up in hospital with a cyst burst. I was overbleeding. I thought it was just overbleeding because of irregular menses and because the condition does lead to overbleeding. But my gynae then referred me to the ER. I got there, she did scans, they did tests, they realized that I'm actually, a cyst is bursting in the moment, right? And she found that there actually were more cysts on my ovaries. But because she knows me and she knows my history, we've been together for over 5 years, she then said, we will not perform the surgery because if we do, we risk losing your ovary, and because we're trying to keep it for future because I want to have kids. And she's like, already your fertility might be a challenge. We don't want to damage natural organs. So I think for me, that's the importance of sticking to one gynae. They know your history. They will help you in ways that will be beneficial to your journey. Question we got, someone was asking about any tips on how to deal with hair loss, especially around your hairline.
Yeah. So hair loss is part of the big feature, the 3 criteria of PCOS, which falls under the excess of androgen levels. So hair loss is one of the least. So the hyperandrogenism, we see hirsutism, which is increased hair or excess hair on the chin, on the lips, on the chest, on the back and upper thighs, where usually you wouldn't have. So those women have more testosterone, where men will have hair on those areas. That's when we see women. The second one will be acne. So increase of androgens and steroids and all that will still manifest in acne. And then list, which is not much explained and the whole pathophysiology is not known, will be alopecia. So you are losing hair. So like I said, the medication and all that is the balance between this androgen excess, which they will give you as part of the medication, which is
so the person must go either to seek help, particularly for that.
Then we'll do your androgen levels to see which kind of hormone are you having excess or lacking. So in that way, that's when you're gonna have. And then we also give advice in terms of referring to dietitian according to what you present with,
or dermatology.
What did I say?
Dietitian.
Sorry.
That's right.
Dietitian. I wanted to say dermatology. Yes, especially with the hair, with the acne, and also managing it. But you need to.
So I just don't wake up now. Let's say my hairline is reclining, and I say
no. And remember, it's a combination, so you can't just have hair loss only. Are there any other elements that you have in combining with that? It could be just purely genetic. It could be just getting old. It could be the other elements. Why?
Could be the braids.
Yes, you are losing hair. So you can't really answer it just isolated. You have to see other factors as well. We're talking about us black people. The one thing that comes to mind, because I work in a state hospital, is that people are not seeking medical help, not because they don't want to, but it's because of finances. Like someone who has a medical aid, is easier for them to pop in a GP. It's more convenient, and then they are being diagnosed. But then if you have a disease like PCOS, especially if it is not diagnosed yet, there are so many things. You don't have money for blood test. You don't have money for imaging. So, however, there are screening tools. Yes, in clinics they're not going to diagnose you with that, but then they can refer you, just having the symptom of irregular menses, of not having menses, to a state hospital where we can have help, because that's the one thing why a lot of people go undiagnosed, because it's tiring to always go to hospital.
And I think you bring a very important point, particularly in a society like South Africa, where we have a lot of inequality and poverty is prevalent, and some people might not have access to private health care, right? And I'm just thinking about myself, the amount of money I spend on my journey. Like, I mean, a gynae consult would be like 3,000, and then if she does a vaginal scan or whatever, or
even if you do have a medical aid, and it depletes.
It depletes. The funds get depleted. You have to do blood tests regularly.
Take someone who is very disciplined and really want to get this diagnosed, whatever they're going through, and they don't understand what is happening.
But I think the message is there is help even in state hospitals. So there is help even in state hospitals. So don't think because you don't have access to private GP and gynaes, yes, the queues are long, the experience may not as be comfortable and convenient like it would be if you go the private route, but I think the message is there is help, so do go. Even if you don't have access to a private gynae, go to like a state hospital, a clinic. I tell them
ask around.
Yeah, social media.
Symptoms. What can you do? Obviously, I'm not gonna give you the whole management. I can just advise you. Okay, maybe it's this, but then you need to see someone who would actually help you further.
No, that's important. Thanks, Boo, for that. And I think it brings us to the end of our episode today. I think I learned a lot as well, because sometimes you think. And I think my whole point of sharing my journey and doing this episode is that you don't feel alone. I think the biggest part of PCOS is you live in your head so much. And you live in your head so much, and you might feel like this is just a me problem. Like I'm the problem, or this is just my condition that I have to bear to the grave with. But you're not alone. Many people are living, and we're living well, healthy.
Especially when the doctor tells you, infertility issue.
Yes.
You're not going to have kids.
And you overthink.
Your ovaries. You must have an IVF.
You know, my gynae actually recommended that we freeze my eggs.
Well, go for it, boo.
And I was like, what? No, I was not happy. Like, my reaction was not. No, let me tell you, my experience was not your reaction, right?
Get your husband and get them kids.
That's what she's saying. So she's like, and for me she's been trying to advise me to get kids since like a long time now. But for me, I'm like, but it's not my life plans. And I think that's the frustrating part about the disease, that your life plans and your dreams now need to be altered to suit the condition. Because now I can say, maybe I had dreams of getting kids when I was 40. But now, because I'm told at 25,
it's called life. It is an unfortunate thing, but I think it's something that you're not going to wake up and say, I'm going to have a husband, I'm going to have... And that's the most difficult thing, and that someone now is trying to...
And that's why I think...
live a life, because now they have this kind of disorder.
Yeah. But then I feel like, for me, is the problem about the disorder is that now you're starting to live a life dictated by it, not by yourself. And you might find yourself making mistakes, because now you can rush into things just that you can soothe that element that I want kids, that I don't deal with a lot.
At the end of the day, we are just doctors, we just give advice.
Exactly.
But then there are other things that you think the God Almighty will do it, and we've seen it happen. So
me, I'm a believer. Yes. And my gynae is also a believer.
This is what we will tell you as medical doctors, advice and all that. But
so I think, any other thing to add in terms of, or a message to those living with PCOS, or those who have not yet been diagnosed?
So my words go out to all the women of reproductive age. This could be everyone that has started their periods up to menopause, because the diagnosis starts as adolescence up to menopause. Like, if you start seeing symptoms like your periods have started and then after 6 months you don't see them, it could be normal, it could not be normal. So don't ignore the signs. Go see a GP, go see a specialist. Other symptoms that you cannot understand about your body, seek help. Be diagnosed of this disorder or syndrome at an early age, so that you are able to be managed. It is quite difficult. Some is misunderstood, like we said, but seek help earlier. Don't be afraid, because I know if it's not pain, people don't come to hospital.
Yes,
and you feel comfortable.
I actually think I wouldn't have gone to the gynae had I not had pain.
You see?
And I think because the pain was...
Don't be like her.
Because I think for me the pain was exaggerated, because I was also having endometriosis at the same time. So because I was ignoring the hirsutism, I was ignoring the...
you start seeing someone in hospital, now they have a baby. And when you operate, you're like, didn't you see this big fibroid? It's a huge fibroid. And they're like, no, I was not in pain. They can see their abdomen distending, their stomach is growing, but they don't feel pain. No, it can't. So seek help earlier. And those who have been diagnosed with PCOS, living with PCOS, I think it's quite a difficult journey. Big ups to you. hope that you are aware of this disease. Teach other people and other women in the society to be aware of this disease or a syndrome, so that we're able to help each other, help a sister, help a mom, help a friend, so that we are aware and we are more educated about this PCOS that we're talking about. Yeah.
I think from me, my last words, particularly those living and as someone who is living with PCOS, I think acceptance is key. And if maybe you get diagnosed, or after this episode you go see a gynae and you get the horrible news and you get diagnosed, acceptance for me is key. The sooner you accept, the easier the journey gets, because once you accept, you then be able to also be open with your family and your friends and your loved ones and those around you, for them to offer you the support you need. But also you then minimize the frustration, because the frustration can make you to become a non-compliant patient. I was for years, not even months, years. But once I accepted and I realized that's something that I'm living with, I've been dealt with, it's okay. There are days, there are good days, there are very bad days, but it's manageable. I think for me, I found a routine to manage it. There actually are some supplements that people recommend, like you were saying, that outside of just the medication, like
and apparently vitamin D,
yes,
the new evidence-based is becoming the more new treatment for PCOS, which we don't know is going to be a permanent cure for it. But then there's vitamin D, and there's new evidence of new treatment for actually this disease.
But yeah, guys, so I hope you take something from this episode and this conversation. My whole point of sharing and bringing Dr. Sesi on the episode is that you learn and we start taking more responsibility over our reproductive health, particularly as women, right? It's our responsibilities. We take care of our bodies. So thank you guys for joining us to another episode of the conversation between me and Dr. Sesi, our experts today. I hope, like we always say in this channel, that you take the conversation. The conversation does not end between the two of us today. You take the conversation, go share it with your mom, go share it with your sister, go share it with your friend, your loved ones, whoever, and have the conversation. If you start seeing symptoms, go get help. There is help out there, even if you don't have access to private healthcare. Even in the state system, there is help. Do not get discouraged, even when the system is not as friendly and convenient. The most important thing is for you to go get help. So from me, Dr. Boo, follow her on Instagram. Her handle, Khanibee 12.
Yeah.
You don't have Khanibee 12?
12 is on Twitter.
Okay, yeah, anyways. But you have numbers. Dr. Khanibee, that's it. I'll put it on the thing.
At Dr. Khanibee.
At Dr. Khanibee. Like, comment, share. Let's keep the conversation going from me to you. I love you. Stay healthy.
Bye.
Bye.